We will use the 6 mm Artisan lens. A 6.1 mark is performed and a 6.2 incision is needed. The sight is always on the steepest axis of the preoperative astigmatism. A perpendicular non-perforated 0.25 limbal incision is performed with a diamond knife. Now the two parasyntheses are made. Look at the direction of the knife, always in the direction of the site of the enclavation and never in the direction of the pupil. We bring the pupil down with a myotic solution, and after that we inject cohesive viscoelastic device on the left and on the right side to refill the anterior chamber. Now the main incision is completed with a classical Phaco 3.2 diamond knife. The point of the knife is directed towards the pupil. Then we check the parasynthesis with the enclavation needle, here on the right side and now on the left side. We apply some viscoelastics on the conjunctiva to avoid any contact between the IOL and the conjunctiva flora. The lens is introduced in a vertical position into the anterior chamber through the main incision without any contact with the pupil, the anterior chamber and the endothelium. Much viscoelastic device between the IOL and the endothelium to push the Artisan lens on the iris and to have a very deep anterior chamber. We rotate the lens into a horizontal position with a dialer, and you see that this instrument has a triple function: a crochet, a fork and a dialer. We center the lens in function of the pupil. Now some viscoelastics is injected at 12 o'clock between the iris and the lens to facilitate the grasping of the IOL. Here we grasp the lens with the holding forceps in the left hand and we enclavate with the enclavation needle in the right hand. With the needle we create a wave just on the claw of the lens, a wave of iris, and we push the iris into the claw of the Artisan lens. Again with some viscoelastic at 12 o'clock. The same maneuver is done on the left side. We hold now the holding forceps with the right hand and we will enclavate with the left hand. Exactly the same maneuver. We create a wave of iris under the claw of the lens and we push the lens into the claw. So that we finish now with a well-centered lens. We will check the centration at the end of the procedure without any viscoelastics, only in presence of BSS+. Don't forget to perform a peripheral iridotomy with micro scissors. Make sure that both layers are perforated so that you can see the fibers of the anterior capsule. Suturing of the limbal wound with nylon 10.0. It is a refractive procedure in the sense that we try to avoid induced astigmatism. If we have too much induced astigmatism after 5 weeks, we can remove the sutures so that the induced astigmatism disappears. You can see that the anterior chamber is always very deep with the cohesive viscoelastics. You will see in the book why we prefer cohesive and not dispersive viscoelastics. We must be very careful with the 10.0 suture. This could be considered a drawback of the Artisan lens, the incision of 5 or 6 mm. you will see that with the flexible Artiflex lens, the flexible model of the Artisan lens, it is not necessary to place sutures at the end of the procedure. But here, with the 5 or the 6 mm lens, it is necessary to suture the wound, independent of the type of incision, corneal or limbal or scleral. A first knot is made of the suture, and now we will remove the viscoelastics with the cannula by injecting BSS+. Other techniques can be used to remove the viscoelastics, for example the classical irrigated aspiration technique of the phaco procedure. Place the first knot and then check the light of the microscope on the cornea to see if we have a round or an oval light. Try always to end with a round light on the cornea, a sign of not too much astigmatism. Now we have to check the centration of the lens in presence of PSS+ and without any viscoelastics. You see that we will finish here with a well-centered lens, horizontally as well as vertically, and with a well-reformed anterior chamber, so we can leave our patients in good conditions.